A very good morning to all. So I'll be talking today on comparative analysis of tumor control by indigenous versus imported ruthenium plaque brachytherapy. We have no financial interests. So as the evolution of plaque has seen over a century, we have gone all the way from Dushman, where in 1915 he started assessing the different materials that can be used or radioactive isotopes that can be used for plaque brachytherapy, the different placement techniques. We have gone from radon all the way to iodine. We have gone to the COM study, which proved that plaque brachytherapy is equal to enucleation, therefore it should be preferred. And we have gone all the way to episcleral plaque brachytherapy. This is how we have evolved. And we have seen that ruthenium plaque brachytherapy, which is a beta emitter, has been used because it's a longer half-life than the others. It has reduced dose delivery to the normal adjacent structures, and it has lesser radiation-induced side effects. This is the reason why we prefer ruthenium for surface tumors, as even conjunctival melanoma, even iris melanoma, and in cases with intraocular cases like choroidal melanoma, choroidal hemangioma, and even for retinoblastoma. So this is the spectrum for which ruthenium plaque brachytherapy has been used over the years. And this is the plaque that we have been using all the way, which had high cost and import duties. So this is the imported plaque that we were using for all these years. And because of the import duties, we had limited centers for plaque, restricted availability, and affordability issues. So to combat that, we went into the Make in India, Recreate, wherein India goes indigenous. And we came up with the plaque brachytherapy, which is absolutely indigenous, and that was developed by BARC, which is a low-cost plaque. And this has been made from Kalpakkam radioisotope waste, and it has been purified, and it has been put together and electroplated on the plaque. And that's how we have come up to the study wherein we are comparing that the plaque that we have been using all the way, is it similar or is it better, or how is it to the new plaque? Because before doing something, we need to have a correct proof for it. So therefore, we assess the local tumor control in all the surface lesions and intraocular tumors between the two plaques. And we did a retrospective analysis where we had nearly 315 cases in the imported plaque and 101 cases indigenous. This is the spectrum of how we exactly do the plaque brachytherapy, where there's a diagnosis made, documentation is done, assessment is done, dosimetry planning is done, and therefore plaque is inserted, regular follow-up and documentation comparison is performed. This is the video all the way from 2020. That's when we started the plaque brachytherapy. And as you can see, that because of the indigenous plaque, we have been able to bring this all the way to India in our own state-of-art ORs. And we have been able to successfully perform these procedures. So if you can see over here, the analysis showed that we have nearly similar outcomes in both the plaques. In ocular surface lesions also, we have gone to a good vision salvage rate, to a high eye salvage rate, and 100% life salvage rate. And we are changing the face of it, and we have a good follow-up now. So this is the analysis which has been done earlier. But have any of the studies commented on the cost? No. So we have been able to comment on the cost, and we have been able to state how it's different. So if to summarize this and make it easier to understand, if we talk about ocular surface lesions, with the imported plaque, we have been seen that life salvage is 100%, eye salvage is 100%, and vision salvage is 78%. As you can see, excellent outcomes there. If we talk about the indigenous plaque, that is the BARC plaque over here, the vision salvage is 80%. We have seen excellent outcomes with even this plaque. Now when we talk about the intraocular tumors, the salvage rates are also very high. 100% life salvage rate, 81% for the eye, and 60% of the vision with the imported plaque, and see excellent outcomes over here. Again, there's a slight increase in the indigenous plaque, could be because of a different follow-up. That is 96% in BARC plaque with excellent outcomes, as can be seen over here. So if we say, we can conclude that indigenous plaque is non-inferior or statistically non-inferior and therefore similar to the imported plaque, but there's a cost reduction by 95%, which is a very significant cost difference. So we suggest the usage of this indigenous plaque for the intraocular tumors and the surface tumors, as it is non-inferior to the imported one, with excellent long-term vision, eye and life salvage, with significant cost reduction. 95% is no joke. An increase in availability to the society, and we have been able to support the Made in India initiative. Thank you very much.
I congratulate you on conducting such a beautiful study and designing it this way. Ma'am, any questions?
Wonderful presentation and a very good lesson for us to go indigenous.
Very nice.